One of the things I like doing, being one of the last presenters, is I can pick up themes that have come up and talk a little bit about them in my data. This was the section on new challenges, things that we need to be working on as we move forward in driving safety. The first thing I wanted to do, Faye had talked about it earlier, the state of Texas collects admission data on every client admitted to substance abuse treatment, and it's the usual age, race, sex, the problem drugs. It also picked up where they are referred from, and this is a data set, the ones I'm looking at. In entering treatment, the question was, have you had a DWI or a DUI in the last year? So we're talking about people who have been arrested for impaired driving. Okay, anyhow, this is where they were referred from treatment. And this is the other law enforcement referrals. And it's kind of interesting because you get people like cannabis who were probably referred for other offenses. They weren't arrested, they weren't referred from DWI. And here are probationers from other probation agencies other than the DWI probation agency. So you can see cannabis offenders, even though they're all DWIs, are referred from other probation, as are methamphetamine and cocaine. Now here are the DWI probationers. And 53% of those with a primary problem with alcohol were referred by the DWI probation department, some from cannabis. And what this is saying to me is, if you have a primary problem with alcohol, you're probably going to be screened and referred to treatment for alcohol. If you were arrested for something else, a petty crime or something, we may not screen you. Now this is self-referral, and I'm sorry the timer's getting ahead of me, but what's interesting, okay, now, all right, now stop. The self-referrals were primarily for other opiates and heroin, and I think it's one, sick and tired of being sick and tired. The DWI arrest may have been the seminal point that got people to come to treatment. They weren't screened for alcohol or for other drugs when they were arrested, but it's like, this is the straw that broke the camel's back with the family and friends. You're going to treatment, you've got a problem. In Texas, unfortunately, when probation screens, they use the MAST. The MAST only asks, do you have a problem with alcohol? A lot of the screening instruments that are commonly used don't even ask, do you have a problem with drugs? And the American Probation Society has a new one that looks pretty good, but it only asks, do you have a problem with drugs? It doesn't say with cannabis or with heroin or methamphetamine. So one of the problems is we're missing an awful lot of offenders who ought to be in treatment, and the DWI probation department needs to be picking them up and getting them into treatment rather than letting them end up coming to treatment for some other reason. And then let's look at the drug combinations. This is alcohol. If your primary problem was alcohol, if your primary problem was cannabis, cannabis, 47% of the people with a primary problem with cannabis had no other secondary problem. Of those with a primary problem with alcohol, 15% had a problem with cannabis. Now, a couple of things that are interesting. Of those with a primary problem with alcohol, 13% had a secondary problem with cocaine. If you take cocaine and alcohol together, you get cocaethylene in the stomach. It's a much better high than cocaine or alcohol separately. So there's a relationship there. And with heroin, you see 26% have a second problem with cocaine. These are the speedballers. Speedballers, we think of it as cocaine and heroin. They don't do both drugs together all the time. When I wake up in the morning, if I've been doing heroin, I'm going to start going to withdrawal, so I need to get a heroin shot right then. Then a little later in the day when I need to get up and put some clothes on and maybe go out and borrow a TV set from next door or something, then I take some cocaine to get me up and moving. And then you kind of go back and forth, and then when it's time to go to bed, I take more heroin. So that's one of the relationships that occurs. But of special importance, whereas the alcohol, 66% have no other drug problem. Look at sedatives and other opiates. The sedatives, 17% have a problem with other opiates, and of those with a primary problem with opiates, 26% have a problem with sedatives. We've been talking about the role of benzos, and I think more and more I'm seeing the problems, benzos and other opiates, the pain pills. We've all got pain pill epidemics, and if you look at it, they're doing pain pills and benzos, either first drug or second drug. And we need to be paying attention to that because those are the ones that I bet are going to show up in John Lacey's new roadside survey. It's the Friday afternoon ladies who are out doing whatever with benzos and other opiates. But the other thing I want to talk about are these new drugs that are out there. Cannabis versus the cannabinoids. The synthetic spice and the cannabinoids, their history, in case you don't know, we know there's a relationship between THC and the pain centers in the brain. We obviously have a lot of that going on with medical marijuana, but never been able to really figure out exactly what it was. So there were 3 different labs that were looking at this, and they were going to use rats. Well, rats don't smoke dope, so you got to figure out how to get THC in them. So they were coming up with synthetic versions to mimic or to beat THC. Well, you do it on a university campus, and the formulas are going to walk out the door. And so that's exactly what we're facing with the synthetic cannabis products now. These were set up originally to try to test the effect of pain on THC. The sensations between cannabis and the synthetics, about the same, but the differences are the seizures, the nausea, vomiting, the coma, and the agitation and violent behaviors. So some similarities and then some very important differences. Then let's talk about the bath salts. They mimic the effects of the khat plant. And the khat plant, in a lot of ways, it's a native African plant. And if you chew on khat, you get kind of the opposite of the kava plant in terms of a speeded up. Khat is going to speed you up. It's more like a stimulant, whereas the kava puts you to bed. These are sold as legal highs, legal cocaine, legal ecstasy. Serious side effects, always labeled not for human consumption. And we're seeing more and more of the cathinones. A couple of things, the data in the U.S. On the left are the calls to Texas Poison Control Centers, and you can see the synthetic cannabinoids peaked in 2011, but we're going to beat that in 2014, and it's because we've had a chain of head shops who figured out they had, quote, the magic recipe. They were ordering the raw chemicals from India and China, and then they had this recipe that they thought they knew what it was. And so they would mix it up in the back room of the head shop. And you've seen all the pictures of the baggies of spice and stuff. You buy the baggies from a production company, and then once you mix up your magic formula, then you fill them up in the baggies and sell them. What's in baggie 1, even though it looks like baggie 2, can be very, very different. But that's what has happened. It's led to the increase in the first 9 months of 2014. Nationally, same thing. The synthetic cannabis looks like it's leveling off, then a complete drop in the cathinones. So that's what we've got there. Now, this is looking at the treatment, the poison control data for synthetic cannabis. Then the middle column is treatment data from Texas treatment programs. And then the right is the 2010 through 2014 cathinone. Very clearly, all three groups, they're males. 3/4 of them are male. The cathinone patients are older than those who are seen in the poison centers or in treatment for cannabis. They intended to abuse. The cathinone cases that ended up in the emergency rooms had more severe effects. A major effect or life-threatening is that after they were treated in the emergency room, they did not return to their normal self. So these are the ones that have the more serious side effects. 4 deaths for cathinones, 4 deaths for cannabis in Texas. But that's a pretty healthy data set in terms of the numbers of people. This was the one I wanted to come in piece by piece. It hadn't happened, but let's talk about what's going on. If you look on the left, look at the orange. That's 2010. The first drugs, synthetic cannabis that came to market were in the orange bars. And look at how the orange just disappears. By 2013, there is no more of the JWH versions. These are the John W. Hoffmans that were first synthesized. They've disappeared. You see by 2011, we're into the AM 2201s. 2013, we're into the XLRs. And by 2014, the others. More and more types, more differences. But the take-home message here is if you are testing for synthetic cannabis, unless you have the very latest test kit, you're wasting your money. Because if you look at what they say they're testing for, if you're not working with a good toxicologist who really knows what they're doing, you're just buying it off the shelf at the drugstore or the traveling salesman, people are going to test negative because they're not testing for the right variety, because we've got 50 different types that need to be tested for. And then the cathinone items. Okay, 2010, you see the MDPV, the mepridone, and the methylone. And then by 2012, we've got more methylone, more alpha PVP. By 2014, the same thing. In 2010 and 2011, we were all worried about mepridone. That was the worst one. Now it's disappeared. So it's just a continual revolving pattern. And there are more types, there are more items. And from the term bath salts, we've now gone into 4 basic categories. And I'm boring you to death, but you need to know this because we're seeing shifts to more and more. The synthetic cathinones, we've talked about the bath salts, the mepridone, the methylone. They're stimulants, they're similar to methcathinone, MDMA, and amphetamines. The 2C phenylethylamines actually go back to Shulgin's drugs I have known and loved from years and years ago. Mescaline, the psychedelics, then the tryptamines that Chris Wilkins did some very nice work on the peppers, excuse me. The tryptamines are the psilocin and the bufotenin. Jeremy, what's the name of that toad in Australia? Cane toad. This is the toad liquors. You lick the back of the cane toad or some other toads and you get a psychedelic effect. Now, if you're as old as I am, you can remember when people did this kind of stuff 30 years ago. So a lot of these drugs are out there, are still coming back. And the peppersines, the BCP and TFMPP, when mixed, pretty much resemble, they weren't as good as ecstasy, but we've had a shortage of ecstasy until very recently, so they were mixing these up in place of ecstasy. And the phenylethylamines, 10 years ago, we talked about bees and Nexus. They're still out there, hallucinogenic effects. The N-bombs, are the super potent version of the phenylethylamines. These are the ones that can be deadly if you get too much of them. We're seeing often they're on blotter paper, just like in the old days where you put the LSD on the blotter paper. And then these are the numbers that show the increases in phenylethylamines in the U.S. This is looking at MDMA, and I wanted to bring this up so you could be aware because it's going to affect the testing. We've had a shortage of MDMA. Paul reports that the labs that used to make MDMA in Belgium and Luxembourg were shut down, so there wasn't much around. Everybody talked about it. Now, evidently, some of those labs are back in business, so we're starting to see MDMA come back. So when you run the tox test, the numbers are going to go up, and it's simply a market force. But on the left is showing if you shave off a little piece of the pill and send it to the lab, they'll tell you, is it all MDMA? Does it have any MDMA in it? And so you can see that both the blue, which is all MDMA, and the orange, those numbers have dropped. On the right, you can see ecstasy really takes off, the yellow line, until 2010, and then it has dropped like a rock. At the same time, the synthetic cathinones have taken over. So we're seeing a real shift from MDMA to the cathinones. Bauman of NIDA is reporting that mepridone and methadone act on the brain like MDMA. So what we think maybe in some of these cases, until the toxicologist can work them, maybe it's not MDMA, or it may be the methadone or mepridone in addition to MDMA, which just makes it more confusing. And to show you kind of what's going on over time, there's psilocin, psilocybin, they're the tryptamines, they're the phenylethylamines, the MDMA, and the cathinones. So just think about how do you keep up with these, and how do you test for them and figure out what they're doing. On our website, we have a training package on these synthetic drugs. It's free. You're more than welcome to it. You can pull it down and cut and paste whichever slides you want out of it. And the best part is at the bottom it has the cheat sheet with this is a chart that describes blah, 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 blah. So you can present it. People think you're a genius because you are so knowledgeable about it, but you're just sitting there reading the notes at the bottom. It's already out of date, but it's very helpful. Feel free to download it.